All right, Francis, thanks for joining me in the discussion around exercise prescription to support the management of osteoporosis. So these are the guidelines that were released earlier in February this year, 2024, for physiotherapists and exercise physiologists or exercise professionals. I just want to unpack this a little bit more because we know exercise is essential in the management of osteoporosis, but it tends to be underutilized due to lack of knowledge or, I guess, concerns around the risk of injury through exercise. But some alarming stats, as we know in Australia, where 2/3 of people who are over the age of 60 have osteoporosis or osteopenia. And the significant burden on the medical system is a lot, where osteoporosis and related fractures cost around $2.6 billion per year just for fractures alone in Australia. And with that stats really alarming because it's around 5 to 6 minutes, every 5 to 6 minutes in Australia, someone's admitted with a osteoporotic fracture to an Australian hospital. So these guidelines hopefully help us exercise professionals to help our patients to build better bone and stay on their feet and not fracture. So you've had a read of these guidelines. Curious to know generally what's your thoughts about them and how do you use them in your practice?
Yes, I have read through them and I really like how they're really clear. I think you can just sort of pick it up and read it and get a pretty good idea of what you should include, to the point of, I even think if patients themselves came across it, I know it's pretty easy to find online. I feel like it's clear enough that they could sort of get a bit of a background understanding, which I think is good. Although I do think that if you actually have a diagnosis of osteoporosis or osteopenia, it should be guided by a exercise professional. So I think it's good that it includes strength training and that it has balance training as sort of the main parts of it. I suppose there is some maybe debate around the impact loading, although I can see that that was graded as like top level consensus. So I suppose there's not as much debate about that as I thought there was. And I liked it how it has that whole bit about being patient-centered and how, you need to dose it according to where the person's at and focus on what they can do as opposed to what they can't. Because I think a lot of people with osteoporosis are often given the message like, avoid this, whereas this is sort of saying the opposite.
Yeah, that's true. There's a general consensus that you need exercise to avoid fracture. So you're either building bone, so you avoid lower bone mineral density, and you're normally doing that through strength or power exercises. And then the other part is you build better balance, so you have better spatial awareness and proprioception, so the individual would therefore not, fall, which results in a fracture. So you're running your own gym exercise facility as a physio. The difference between these exercises, can you discuss what type of exercises you use for your clients?
Yeah, so I'm going to say the strength training side is what I focus on. So the guidelines specifically say 2 to 3 days a week, 2 to 3 sets of 5 to 8 repetitions at 75 to 85% 1RM of progressive resistance training. So I probably do very slightly differently. Most of my patients who come in, they come in twice a week. So I guess it's on the minimum side. And that's probably just more like practicality and cost for, I'd say, people that have their own gym membership. I encourage them to go that third time, but for people that are coming in to see me, it tends to be twice. And then I have to say the 2 to 3 sets of 5 to 8 repetitions, we probably do more than that. I almost never only do 2 sets of exercise with people, because to me, if you're only doing 2 sets of 5, you'd have to be lifting it'd have to be very high intensity lifting. Like I feel like for that to be effective, you'd have to be really doing 85% 1RM lifting. Like you'd have to be lifting weight that you really only could lift 5 times. And I suppose I found with this population, they don't have a training background and they're pretty new to exercise. I find it very unlikely that they're lifting 85% of their maximum possible lift. So I sort of feel like if we only did 2 sets of 5 of an exercise, they're doing 10 reps. It's probably way below how much they could actually be lifting. So we tend to do more than that. So if we're only doing 5 reps, we tend to do the 5 rounds of 5 reps with warm-ups as well. So we'll usually do 2 or 3 warm-up rounds. So you end up doing 8 times 5 in total. And then if we're doing sets of 8, I tend to do 4 sets. And I just think it's the total number of reps you're getting out there. So 5 by 5 is 25, 4 by 8 is 32. If you're lifting pretty heavy, I feel like that's adequate.
Enough of the stimulus,
so it's slightly more than what they're suggesting. But again, that's just from having worked with these population that I know it's a thing that if you did 5 reps of a weight, you could actually lift for 20 reps. It's not doing that much. So I sort of get around that by doing more of them instead of less, if that makes sense. Yeah,
that makes sense. Yeah. And what's your sort of opinion on those with your patients or the classes? Is it more of a one-size-fits-all approach where everyone gets the same exercise and then your load is different, but your reps and sets are the same? So you might have someone who's older or younger with different strength capacity. So everyone has a one-size-fits-all where they're getting the same exercise with different loads, or does everyone have a specific individualized program?
Okay, so we have a beginner program that is entry level for people that have never exercised before or have never done gym exercise before. And that program is basically like what I always say to people, the exercises are the same across the board. So it might be you're doing a hip hinge. So if you're brand new, that might be like an unloaded hinge at the hip, or it might progress to like a 5 kilo dumbbell. If you're really experienced, you might be lifting probably not double body weight, 1.5 times body weight on a deadlift. So like the foundation movements are the same. So we have the beginner program. We don't put jumps in that program. So we sort of use about 6 weeks to people to build up to next stage. If they're not ready to go into like our general bone density program, we just like keep repeating beginner level programs until they're ready. So I'd say the majority of people, we have this like base program that is the bone density program that most people are on, but then you can have two people who are following it and like they actually might not know they're doing the same program because the variation in how they're doing it might be so significant. So I do include low reps as the year goes on. So say because it's the end of the year, we're doing heavy, like 1, 2 or 3 reps at the minute. So people who've been training consistently all year and they're confident, we might actually work up to like, okay, let's do a heavy 2 or a heavy 3, where they're lifting like very heavy for them. Whereas someone else might be following the same program and we go, oh, we're not going to do those low reps with you. We're going to just do the standard like 5x5 or 5x6 of that particular movement. So it's usually the deadlifts that we do that with the trap bar or the straight bar. And same with, we often have barbell back squats in it, but for people that can't manage that, we'll just do like a goblet squat instead. So there's sort of a foundation program, but then we make modifications around it. And also if people have injuries, we'll swap things out. For anyone that's had an insufficiency fracture, we don't do jumps, so we swap them for something else. So it's individualized, but with the same base.
Yeah. Because the guidelines recommend that progressive resistance training of 2 to 3 a week, and you're saying sometimes most of your patients are on the minimum side of that, the 2, and then there's weight bearing and impact training, which they recommend 3 times a week. Do you generally think that's enough for them? I know you said one day a gym, they might go to the gym themselves or do other things, but the guidelines are saying 2 to 3 or 3. Do you think that's enough to see changes? We know bone adaptation is about 9 to 12 months, sometimes 6 to 12 months. Do you generally think that's enough for the individual?
I guess from some of the research that formed the guidelines, maybe it's like the minimum amount. So it's like 2 days a week is potentially enough to cause difference. Like we think of Lift More trial, I always just think of that one. They only did it twice a week. But obviously doing it 3 times would be better. For the people that I'm really comfortable to do jumping with, I have actually told them, because I think the guidelines are, minimum 3 days a week for that.
Yeah.
I think I've said to them, you should include that on days you don't come in.
Yeah.
But there's not that many people I've said that to, because
most people would probably generally require a day of rest in between anyway. So there's like a Monday, Wednesday, Friday, or a Tuesday, Thursday, Saturday approach that sometimes works better. And these people are probably generally active, walking the dog or doing other things around home. They might go to a Pilates class, yoga, like they're still active. That weight bearing and impact approach should be 2 to 3 times.
Yeah, and that's the thing as well. I feel like the guidelines were pretty generous as to what they classified as exercise that counts. So say that when they talk about falls prevention exercise, so exercise will prevent falls if undertaken more than 3 hours a week. Like that's heaps. I tend to think lots of different things that people do probably counts. Like, so we don't really include, I don't do much just straight balance exercise because I feel like standing on one leg, it's boring. It doesn't do that many things. But we do things like say if you do, we do like step back lunge to knee lift. So that's hard to balance because you're balancing on one foot. You've got to like lunge and you have to go up onto one leg for a second. Or like step ups, which is the light tap down at the back. Even jumps, landing from a jump, landing from a hop, I feel like they're balance exercises because you have to land. So I feel like in the classes, you could count them, a lot of it as balance. And then lots of them go like on hikes and stuff. That's got to be balance challenge. Yeah, so I feel like there's probably a fair bit people are doing day to day that will help them out. But I suppose, I mean, in my mind, I definitely think 3 days would be better than 2. But it's what's plausible for people. Most of my clients, they like hate the gym. They like coming to a class. They really don't like the gym. They're not going to go on their own. They're not going to do it at home. So it's like, well, you've got to do what? You can't help it if that's your situation. Of course,
yeah. And then some of them, in my patients, you say the same, like swimming might not help, cycling might not help, Pilates might not help build bone. But on those off days where you're not doing weight-bearing impact strength-based training, then that's when you can go do some swimming or Pilates. That's what I generally recommend. And then, as you said, the balance training can be incorporated with strength training if you're doing a single leg step up or single leg RDL or something, single leg to those advanced populations. You're building, I think, balance and strength at the same time, which is critical.
Yeah, definitely. And sometimes I think like some of the exercises we do, I didn't think of them as a balance exercise or even like mobility exercise. I don't think about it until I've seen someone try to do it and lose the balance for a second. And I think, oh, actually, you know, if your balance has declined a little bit, that you can see that it's hard for that person. Sometimes I think if you're really like high level, you can't.
I agree. Because a lot of balance, when people, I know other ex-physios and physios who prescribe the balance, and they just do tandem toe walking, or they might just do single leg balance, close your eyes, or single leg balance and throw a ball, or, you know, that's just a basic type of balance. But I think when you're doing what you said before, and you're doing a single leg balance and you do a lateral bound or a lateral jump and you try to land onto the other foot, that's, you know, a lot better. And that sort of mimics what we're trying to achieve. I think when you're trying to, if an individual's going to fall, they're going to sort of shuffle their step or try use a rapid speed to regain their foot steps. Then doing a lateral movement like that is great, rather than just a single leg on one leg against the wall.
Yeah,
but there's definitely a starting progression, and then you build to that. So
yeah,
I like that.
I think more bang for your buck too, because like we're just talking about how people don't have enough time to meet the guidelines. Yeah. So if you're doing a lateral leap, you're getting some impact as well as balance, or if you're doing step back lunge chin lift, you're getting strength as well as balance. So if you can do that, it's going to be more time efficient.
Yeah, and I agree. Time efficient, and then finances, or you don't want to be paying good money to see a trainer, and then they bring you to the gym and just say, all right, stand on one foot, you know. So I'd rather them do the strength training at home, and while the kettle's boiling, you can be standing on one leg, the kitchen bench nearby for your support. That's normally what I recommend for them.
Yeah.
Yeah. What about you? You mentioned before about those populations with specific limitations, like orthopedic restrictions, where they might have had a knee injury, or they got a meniscus tear, they've got a previous fracture. Because these special populations, sometimes you have to cater certain exercises for them. Studies like the Lift More, that's been shown exercise is beneficial for building bone. They screened out these people. So when they come to your clinic, you're not going to turn them away because of a meniscal injury. So then what's your general approach to cater for them?
Yeah, we definitely have a lot of people who've had hip or knee replacements, lots of people with rotator cuff tears. I think the difference is that we include lots of isolated exercises. So the way I structure it is like it starts off with like big, heavy compound exercise like squat, deadlift, that type of thing. And then probably try and do like similarly pretty big for the second round of exercises. So it might be like they do deadlift first, then we do lunges and rows or something like that. But then as the class goes on, we do more isolated exercises, which they're the types of exercises I find I give out in rehab. So if someone comes in with a meniscus tear, I might give them an isolated quads exercise like the knee extension machine, if they can tolerate it, or hamstring curl or calf raise or something. So I've just kind of incorporated those exercises into the classes. So most of the classes have a series of isolated exercises in them anyway. But if someone's got a specific injury, I might go, okay, for that person, let's prioritize like making sure they have a knee extension exercise every class. And we'll do that instead of doing the isolated shoulder exercise that is in the generic kind of program. And I find that we always get people to come and do an initial one-on-one consultation first, so we can use that session to figure out what exercises they can and can't do. I think they're often quite surprised that there's so much they can still do. I find that particularly with back pain, because they'll often come in and just, you know, I've got hurt my back, kind of shocked that they can do like 80% of the exercises pain-free. So I think, and as soon as you've had that experience with people, you can tell they're really motivated to keep coming, because they think, oh, even if I've like, something's happened and I've hurt my back doing whatever outside of the class, they know they can still keep coming and we can work around it, which I think is really good.
Yeah, I agree. There's always exercises you can do laying down, sitting first, and then on machines, then, you know, weight bearing. So there's a big difference in what people can do. So I hope those patients don't feel limited or that they can't join a class. It's good that you cater for that. Another thing I wanted to touch on was the screening process. Do you use certain assessments then to look at a falls risk, or you're just going based off of the patient's DEXA scan, which they normally bring into you? Are you using any other functional measures?
Okay, this is a good question. We've been trying to. The clients who come to me are pretty good. So like none of my patients that I can think of use a mobility aid, for example. So they're not super high falls risk, but I do remember from working in the hospital, there was like those falls risk scales, like is it the boom bar? That would be something I would use, but at the minute, so what we do in the initial consult is, I suppose like a detailed history is the biggest screening tool. And like really asking someone, like say if we're deciding whether it'd be safe to try jumps with them, it's like, have you done any sort of strength exercise in the last year? No. Okay. If it's sort of a bit putting a few different things together. Like say if it's someone who's just osteopenic in their 50s, has been pretty active doing yoga and stuff, but hasn't done any impact exercise for a while, I might consider that person okay to try jumping with pretty early on. Whereas if someone's over 65, osteoporotic, hasn't exercised in a while, I'd be waiting ages to start with them. So I suppose the things I'm looking at, age does come into it. So I sort of categorize people into maybe like over 65 is probably different to under 50. And then the middle ground in the middle there is sort of depending on how much activity they've done. So that's probably just a bit of a, it's not specific, but that's, I'm thinking about it. Yep, they're DEXA scans. So if they're osteoporotic, I'm way more careful. If they've had any insufficiency fractures, like the most careful of all. And then it's, looking at what they've done recently, and even just little questions like, oh, if you had to run for the train or run to catch the bus, would you do it? Or have you done it lately? Because then, some people, they're not doing anything specific, but they're comfortable to just like jog for the train and nothing's happened. Or lots of them do these like hikes, like these really long bush walks and stuff. So a really detailed history. And then we do take grip strength, because I have read some papers that indicate like it might have some relevance, but it feels like it needs to be basically, if it's incredibly low, it might indicate a link with sarcopenia. But other than that, I don't know how much value it has, but we're doing it. We've been doing height.
Mm-hmm.
Yeah, and that's it. So basically DEXA, height, and grip strength. And then what we've been doing, we have been getting everyone to come in once a year to check where they're at. We keep a record of like the maximal weight they've lifted. And so I'm just kind of thinking of how you train people not in this population.
Mm.
You measure progress by how much weight they've managed to lift. So I'm sort of applying the same thing, because I found that a lot of the outcome measures you could use, like sit to stand in a minute, they're not very good.
No,
I just found if you're fit, you can just max it out.
Mm-hmm.
And, the first time you ever do it, you might be like you haven't exercised in ages and you're not that confident and you're going really slow.
Mm.
But then you might feel way more confident the next time you do it and do them really quickly. Like, I don't know how much it shows. I don't know. Nothing that good.
Yeah, I agree. Wait 1 second. Yeah. I think, it depends. They can max it out in a 30-second sit to stand, but then you can use other measures. I like the grip strength. There's a lot of research on that lately. And then the other part is timed up and go. That's what regularly gets used. Sit to stand, either 1, either 5 or 30. Balance test. But what you're using now sounds great. Yeah, and
we do balance.
Yeah. Subjective tests that you're talking about, like height, that's a massive one. Even if the patient notices they've lost height, if they can't get up out of a chair without using their hands, these are measures that we can use or write down. And then other things that they might notice themselves is like lifting stuff off the top shelf or picking grandchildren up. They're noticing they can do it easier. Which is a big thing, big progression for these people.
Yeah, definitely. And I think we were trying to find something where they'd be able to see a clear progression so that they'd keep motivated. But I found that honestly, people getting stronger and lifting heavier weights is a huge motivator, and it's almost a guarantee. We've just been trying to give more, like draw people's attention to that. Sorry, something loud is happening outside the door. People in the roof. There's people in the roof. That's what's happening.
Weights in the ground, hopefully.
It's people in the ceiling because it's leaking for the rain. But so we do single leg balance. But again, like I just find with so many of those tests, like if you practice them, you get way better at them, and it's hard to know how much they show. I have to say Sarah, who works for me, because she's works in the hospital as well, she's been really good at implementing some of the stuff they use in the hospital, and we've put timed up and go in there, and we just have a few patients who that's relevant for, like someone who did, in the time we've known her, she fractured her hip and she felt like her balance and her walking were really impacted. We did use it for her.
Yeah, so I think, you're right. There's a certain demographic they use it for. That's good. Anything else you think in this space of bone health, do you think what more needs to be done? We've seen some measures or certain screening tools being implemented, but we're seeing a slight decline in minimal trauma hip fractures since 2018, which is a reflection of some of these risk factors being addressed in the preventative falls measures. What else do you think we should be doing as allied health professionals?
I think people should start earlier. Like, so many of the women I meet, I mean, I love it so much that they're people who are sort of, I get a lot of people in their 50s or 60s and they go, I'm at that age now where I need to start doing resistance training. I feel like there's a huge distinction between the falls risk and the bone health exercise, because to me, like I'm 36, like I'm not thinking about falling. So it's not on my radar, and it probably isn't going to be on my radar for ages. And so I feel like the focus on falls risk to get people drawn in earlier, they won't be able to, doesn't mean anything to them, I guess. But the idea that you want to try to build your skeleton, like build it as much as you can, and then hang on to it for as long as you can, the density of it, that idea is super powerful to me. And especially when you know that like the younger you are, the more chance you have of building it up, and the earlier you start, the more likely you're going to be able to reduce the decline. To me, that's massive. Like, I think it's so great these women we meet are starting for the first time in 50s or 60s to try and address it. But I do think a lot of people go, oh, my bone density is fine, I don't need to worry about it. But if you know that it's probably going down, what's the thing about like 1% a year after menopause? Is it that? Yeah, it goes down. Yeah, ish. I mean, I feel like that's such a vague stat, but I think I've read that it goes down about 1% a year, and it's faster, I guess, from 30, and it's faster after menopause. To me, I just think, okay, wow, like even now, like closer to 40 than 30, I'm thinking my ability to like significantly build bone is kind of probably behind me, and now I'm just like, hang on to it. So I reckon that's the thing we actually need to push, getting people to do resistance training and jump training early as possible.
Yeah, I agree. And most of these people that we see, as you said, they might be postmenopausal in their 50s, 60s, even men as well. But it's a highly genetic condition. So most of these people at that age probably have children who might be around that span of, hitting peak bone mineral density or peak bone mass. Trying to tell them to then pass that information on to their kids would be super important.
Yeah, definitely. The kids is the most important of all, because we know you build most of your bone density before 20, right?
Mm.
But I suppose, yeah, I guess obviously my brain goes to the types of people I meet the most often. I'm just thinking of my friends and everything. Yeah. Like, I just want everyone to do strength training, but it's hard to motivate them. But I feel like if the message is out there about how the skeleton works and how you can actually make this massive impact to it, I think, yeah, trying to just keep telling people, and I suppose like improving education from us to health professionals we might meet that aren't up to date with research, because I get a lot of patients that say, I've been told that because I do walking and that's weight bearing, I'll be fine, or because I'm a runner, that'll improve my bone health. And I've had a number of people who are angry because they're like, I was told that this was enough exercise or the right type of exercise. Like, they have taken an interest and they've been told that their walking or their running is the right type of training, and then they feel really angry that their bone density went down. Not to say that it will necessarily not go down if you do strength training, because it's like genetic, like you say. But I feel like people want to know, okay, this is the type of exercise we need to do, and feel comfortable that they're doing it so they know they're doing what they can. So it's like education based.
Yeah, I agree. Yeah, education, advocacy for women lifting weights as well is a big thing. But I'm glad we're sort of seeing that a little bit more now.
Yeah.
No, that's good. All right, we might wrap it up there. Thanks for your time. We'll stop this here.